Years old man is admitted overnight following a road traffic accident. He has an open tibial fracture with 20 centimeter wound with extensive periosteal stripping. He is neurovascularly intact. IV antibiotic and wound dressing has been administered in the emergency department. What is the most appropriate course of action? So a 30 years old patient has open fracture which is of the tibia which is 20 centimeter and neurovascularly intact. IV antibiotic and wound dressing was done. What it is the appropriate next action? Here the options are immediate skeletal stabilization and application of negative pressure dressing, skeletal fixation followed by vascular reconstruction, immediate vascular shunting followed by the temporary skeletal stabilization and vascular construction, combined skeletal and soft tissue reconstruction on a scheduled operating list, and fasciotomy with 4 compartment decompression. First of all, here we can see this is the neurovascularly intact. That means there is no neurovascular compromisation. So in this condition where there is a vascular reconstruction or vascular shunting present, they will not be option. So first of all, let's see the gastrulation type classification, which is the type 1, type 2 and type 3, or grade 1, grade 2 and grade 3. In grade 1 it is less than 1 centimeter wound, in grade 2 more than 1 centimeter wound, and in case of grade 3 there is the more than 10 or 10 centimeter wound. And the grade 3 also divided into 3A, 3B and 3C. Again see the grade 1 to 3, it is low energy, less than 1 centimeter. Grade 2 which is more than 1 centimeter, and in case of grade 3 it is the more than 10 centimeter. And the 3 also divided into the 3A, 3B and 3C. In 3A there is adequate soft tissue coverage present. In case of 3B there is inadequate soft tissue coverage, and 3C there is associated arterial injury. And this point in this patient, as this is 20 centimeter wound, so it is the Gastilow-Anderson grade 3 type of the wound. Gastilow-Anderson grade 3B, that means more than 10 centimeter, and there is inadequate coverage of the wound. So you will require a definitive skeletal and soft tissue reconstruction, and it should be performed out in a scheduled hours, and internal fixation within the 72 hours. So what will be our option? Our option will be the combined skeletal and soft tissue reconstruction on a scheduled operating list, because the initial management all are given here. Here we can see this, the IV antibiotic and wound dressing was done. So now we can wait for a skeletal and soft tissue reconstruction in a definitive day. And as the patient is neurovascularly intact, so when there is no vascular role, here there is no vascular role, so these two options not true. Also there is immediate skeletal stabilization, it also not required. And the fasciotomy only done when there is development of the compartment syndrome, but here there is no feature of the compartment syndrome such as the pain, pallor, paresthesia, paralysis and pulselessness, as they are completely intact. So our answer will be combined skeletal and soft tissue reconstruction.